Welcome to the deep dive. Today we're getting into a really fascinating and I think clinically challenging area of medicine, valvular heart disease or VHD.
It's one of those fields where you really see the old school meeting the new.
Exactly. You've got the classic physical exam listening for that very specific murmur right up against cutting edge imaging and some really complex therapeutic decisions.
And those decisions often push beyond the established guidelines. It's not a small problem either. The sources we're looking at say VHD affects over 5 million adults just in the U.S.
And aortic valve disease is the third most common cardiovascular disease.
That's right, so it's huge.
Okay, so our mission for this deep dive is to give you, whether you're a med student just starting out or a young professional on the wards, a really solid, structured overview. We want to go from pathogenesis all the way to management.
Sounds good. So where should we start?
Let's jump right into the big one, the disease of pressure. Aortic stenosis, AS.
Okay, AS. So the first thing to understand is the pathology. What's actually happening to the valve. And it's surprisingly similar to atherosclerosis.
I found that fascinating. It's not just wear and tear from old age.
Not at all. It's an active disease process. You see the same players, physical stress on the valve, hyperlipidemia, and critically, inflammation.
Which all leads to these calcific deposits that narrow the opening.
Exactly. It's an active, inflammatory, lipid-driven process.
And once that valve starts to narrow, the left ventricle, the body's main pump, has to work so much harder.
Immensely harder. It has to generate huge pressures to get blood through that tiny, fixed opening.
So how does the heart try to cope with that? What's its first move?
The heart is incredibly adaptive. Its first move is concentric hypertrophy, LVH. It thickens its own walls.
Right, and there's a physical law that explains that, isn't there?
There is. It all comes back to the Laplace equation for wall stress. Sigma equals P times R over 2every.
So the pressure, P, is way up.
Way up. So to keep the wall stress normal, the heart has to increase the wall thickness. It's a purely mechanical compensation.
But that compensation can't last forever. It becomes a problem in itself.
It's a total double-edged sword. At first, it's great. It preserves function. But that thick, beefy wall creates two huge new problems.
Okay, what are they?
First, you get impaired coronary blood flow. The muscle is just too thick for its own blood supply. That's why patients get angina even with clean coronary arteries.
And the second problem?
Impaired diastolic relaxation. The ventricle becomes so stiff and thick, it can't relax properly to fill with blood.
So even before the pump fails, the filling fails.
Precisely. And that's what directly causes the classic symptoms.
Angina, syncope, and heart failure.
The classic triad. And that leads to, well, the most sobering part of this whole disease, the natural history.
Which is really fast.
It's lethal. Once a patient with severe AS gets true symptoms, angina, syncope, or heart failure, their prognosis is terrible. We're talking a fatal outcome in just 2 to 5 years if it's not treated.
That urgency is so important to grasp. And it brings us to a really key management point. AS is a mechanical problem.
And it only has a mechanical solution.
So no medical therapy can change the course of the disease.
Absolutely none. Our sources are unequivocal. No drug has ever been shown to alter the progression of AS. The only fix is an aortic valve replacement, AVR.
That's a critical point. So until a patient can get an AVR, what do we do about their other issues, like, say, hypertension?
You have to be so careful, extremely careful, because the valve creates a fixed cardiac output if you give a potent vasodilator.
You'll drop their blood pressure through the floor.
Catastrophically. The circulation can just collapse. So the rule is always start low and go slow with any blood pressure medication.
Okay, let's move on to that mechanical solution then. AVR. We have surgical AVR, SAVR, and the transcatheter approach, TAVR.
Right. And for a patient with symptomatic severe AS, it's not really a choice about whether to intervene.
It's mandatory.
It's mandatory. The mortality rate is just appalling, about 2% per month. That's a 75% mortality at 3 years without treatment. It's a life-saving operation.
The decision gets a little trickier, though, with the asymptomatic patient who has severe AS, the Class C1 patient.
That's the real diagnostic challenge. The risk of sudden death in a truly asymptomatic person is low, maybe 1% per year, which is, similar to the surgical risk at a good center.
But the key word there is truly.
Exactly. How do you know they're truly asymptomatic, especially with older folks who might just be limiting their activity without even realizing it?
So you need to unmask those hidden symptoms.
You do. And that's where exercise testing is so critical. If a patient can't reach their expected exercise tolerance, or and this is the big one, if their blood pressure doesn't rise normally with exercise.
That's a major red flag.
That's an immediate trigger for early AVR. It shows their heart has hit its limit.
Now, TAVR has completely changed the game. How do we decide who gets TAVR versus traditional open heart surgery?
It really comes down to surgical risk. We use formal scoring systems, like the STS-PROM score, that's the Society of Thoracic Surgeons Risk of Mortality score.
And what's the general cutoff?
Historically, a score over 4% would push you into that intermediate or high-risk category, where TAVR starts to look much more attractive.
And beyond the score, there are some patients who are just not great surgical candidates.
Oh, absolutely. Think about someone with a porcelain aorta. It's so calcified you can't safely clamp it. Or someone who's had multiple prior chest surgeries or radiation to the chest.
Those are cases where TAVR is clearly better.
Yeah, being less invasive is a huge advantage there.
But are there situations where TAVR is not a good idea?
There are. Some are technical. For example, if the aortic annulus is just too small, under 18 millimeters, or way too big, over 27 millimeters, the device might not fit or seal properly. Severe pulmonary hypertension can also be a relative contraindication.
You mentioned fit, and that brings up imaging. The measurements have to be perfect. Let's talk about the LVOT measurement.
This is so important for TAVR planning. Getting this wrong can lead to a leaky valve or even an aortic rupture.
So what's the big pitfall to avoid?
The classic mistake is measuring from the virtual annulus. It's a common error, and it consistently overestimates the true size.
So where should the calipers actually go?
The measurement has to be taken at the anatomical hinge points of the valve cusps, and it must be in a plane that's exactly parallel to the LVOT. If you get that wrong, you get the wrong size valve.
That's an invaluable clinical pearl.
Uh-huh.
Okay, let's pivot to the mitral valve, specifically mitral regurgitation, or MR.
And with MR, the single most important concept is understanding the difference between primary and secondary MR.
Because their management is totally different.
Completely inverted, yeah. So primary or organic MR is a disease of the valve itself. The leaflets are messed up, the chordae, the annulus.
Like mitral valve prolapse.
Mitral valve prolapse is a classic example. Or Barlow's disease, the valve tissue is the problem.
Whereas secondary or functional MR
is a problem with the ventricle. The valve itself is actually normal, but the left ventricle is sick, maybe from a heart attack or cardiomyopathy, and it dilates and changes shape.
And that pulls the valve leaflets apart so they can't close properly.
Exactly. The ventricle is the culprit, not the valve.
Now, when we quantify this on an echo, we use things like the EROA, the effective regurgitant orifice area, but the definition of severe changes depending on the type of MED-R.
Yes, and this confuses people all the time. For primary MR, the ventricle is usually strong, so it can handle more leakage. The threshold for severe is an EROA of 0.4 square centimeters or more.
Pretty high.
But for secondary MR, that ventricle is already sick. It can't tolerate much extra volume.
So the threshold for severe has to be lower.
Much lower. An EROA of just 0.2 square centimeters or more is considered severe. This difference is fundamental to understanding management.
Okay. And just briefly on mitral stenosis, MS scripts. The two big causes are rheumatic and calcific.
Right. And they look totally different. Rheumatic MS is all about commissural fusion. The leaflets are fused at the edges and thickening at the leaflet tips. The classic hockey stick valve.
While calcific MS is more of an elderly disease?
Yes. There you see calcium in the annulus, the ring around the valve, but it usually spares the leaflet tips and the commissures.
And that distinction matters for intervention, right?
It's everything. Rheumatic MS can often be treated with a balloon valvuloplasty, where you literally crack open those fused commissures. But that procedure is useless for calcific MS.
Because the problem isn't fused commissures.
Right. Those patients typically need a full surgical valve replacement.
Okay, let's go back to MR strategy. For primary MR, is it better to repair the valve or replace it?
Oh, repair, always. If it's anatomically feasible, repair is strongly favored. For a simple lesion like a P2 prolapse, a good repair can give the patient a normal life expectancy. Replacing that valve is just not considered good therapy anymore.
But for secondary MR, surgery isn't the first step.
No. The first and most important step is guideline-directed medical therapy, GDMT. You have to treat the heart failure. You optimize their beta blockers, their ACE inhibitors. You treat the sick ventricle first.
And does fixing the secondary leak actually help them live longer?
You know, there's no convincing evidence that it does. Surgical or percutaneous repairs can help symptoms, but because you're not fixing the underlying problem, the failing ventricle, they often don't last.
Let's move into our final segment and talk about some acute threats, starting with infective endocarditis, i.e.
i.e. is a true medical emergency. And what's shocking is that about three-quarters of patients who get it already have some kind of structural heart disease.
And the bacteria involved can be really aggressive.
Absolutely. Staphylococcus aureus is a major one, especially in IV drug use or device-related infections. It just chews through tissue.
What are the biggest dangers with IE?
The infection can spread rapidly, destroying the valve. And you have the risk of embolism, bits of the infected vegetation breaking off and traveling to the brain or other organs. That happens in up to half of patients.
So when do you have to rush an IE patient to the operating room?
The number one indication for early surgery is heart failure. The stats are terrifying. If a patient with IE develops moderate to severe heart failure, their mortality with medical treatment alone is almost 75%.
Wow.
But with early surgery to remove the infection and fix the valve, that drops to less than 25%. It's an urgent, life-saving decision.
Okay, another systemic cause of VHD, especially globally, is acute rheumatic fever.
ARF. It's an autoimmune reaction that happens after a strep throat infection.
So your own body starts attacking your heart valves.
That's the tragic part. And of all the things ARF causes joint pain, rashes carditis is the only one that leaves behind permanent damage.
Which means preventing it from happening again is everything.
It is. Secondary antibiotic prophylaxis is mandatory. Every time it recurs, it causes more cumulative damage. The rule is simple. If a patient has had carditis, they need lifelong prophylaxis in endemic areas to stop that cycle.
Finally, let's quickly touch on prosthetic valves, mechanical versus bioprosthetic. What's the trade-off?
It's durability versus the need for blood thinners. Mechanical valves last a very long time, but they require lifelong anticoagulation with warfarin, high risk of clots.
And bioprosthetic or tissue valves?
Less durable, they will eventually wear out, but they have a much lower risk of thrombosis, so you often don't need lifelong warfarin.
And I remember the sources pointing out an interesting fact about age and tissue valves.
Yeah, it's an inverse relationship. The older you are when you get a tissue valve, the longer it lasts. A bioprosthesis in an 80-year-old might last the rest of their life, but in a 50-year-old, it will likely fail much sooner.
Which is why younger patients often get mechanical valves.
Exactly.
This has been such a great overview. I think we've really highlighted how VHD is all about mechanics, whether it's the fixed obstruction of AS or that crucial difference between primary and secondary MSR.
We've hit on the urgency of conditions like symptomatic AS and IE. So to really lock in that key diagnostic concept about MR severity, let's finish with a quick review exercise for you.
Great idea. Let's do it.
Okay, we talked about the EROA. So imagine you have two patients. Patient X has primary MR from a flail leaflet. Patient Y has secondary MR from a bad cardiomyopathy. Both of them have an EROA measured at 0.3 square centimeters.
Okay, same number for both.
Same number. The question is, which patient do you classify as having severe MR and why?
Okay. This goes right back to that different threshold we discussed. You can't just look at the number, you have to know the pathology.
You've got it. So which one is it?
It would have to be patient Y, the one with secondary MR.
And why?
Because their sick ventricle can't handle the extra volume, so the threshold for severe is lower. It starts at 0.2. Patient X, with the primary MR, isn't considered severe until they hit 0.4.
Perfect. That's the concept. The pathology dictates the diagnostic cutoff. A smaller leak is much more significant in an already failing heart.
An absolutely perfect example of how a single number means two totally different things in clinical practice. Thank you for walking us through this.